Hello and welcome to this Veteran and Family Wellbeing series. My name is Dr. Ramesh Zacharias. I am CEO and Medical Director of the Chronic Pain Center of Excellence.
I'd like to take this opportunity to thank our presenters today. Adria Franson, who's the physiotherapist at the Michael G. DeGroot Pain Clinic, and her veteran co-presenter, Stephen LaSalle. This will be followed by Dr. Joy McDermott and our CAF member co-presenter, Robin Campbell. Merci à tous.
Second exposé. Thanks to all of you. I will now turn the event over to our moderator, General Michel Maisonneuve.
Merci, Dr. Zacharias, et bonjour, chers amis. As Ramesh mentioned, my name is Michel Maisonneuve, and I am a veteran of the Canadian Army in which I spent 35 years. I welcome you to another in our series of educational webinars on veteran and family well-being. As you can see, there are two streams to choose from, a French language stream and an English language stream. We are doing simultaneous translation so we can serve both streams. You should also be aware that today's presentations and slides are best seen in full screen mode. Les deux présentations aujourd'hui seront en anglais, mais avec traduction simultanée et diapo en français dans la version française. It has been my pleasure to work with the Center of Excellence on Chronic Pain since its founding. Over my 35 years in uniform, I realized that chronic pain is a constant in the lives of many of our sailors, soldiers, and airmen and women. And for many, this pain follows them into retirement. So it's my honor today to help moderate this seminar. Today we'll have two presenters, and we will take questions after each presentation. I would now like to introduce our first presenters. Adria Franson has been a physiotherapist for 20 years and has received extensive training and education in treating chronic pain. She has been involved in research and presented at various venues. She has supervised physiotherapy graduate students, and she has taught graduate-level physiotherapy courses. Adria has been working with veterans at the Michael G. DeGroot Pain Clinic since 2010, and she helped incorporate the neuroscience of pain into their programming. The goal of today's presentation is to share and discuss her approach to educating veterans on the neuroscience of pain in an attempt to help them understand and manage their pain differently. As we've done in the past, Adria will be accompanied by a veteran, Stephen LaSalle, who will provide his experiences with the subject. Now, over to you, Adria.
Today, I'm going to be talking about the neuroscience of chronic pain, otherwise known as pain neurophysiology education. I don't have any disclosures. And myself, along with Stephen, a veteran who I'm going to introduce shortly, we're going to be talking about how different concepts of pain neurophysiology education, or the neuroscience of chronic pain, was used to help him learn strategies to manage his pain differently. So Stephen, I'd like to introduce you now.
Thanks for the introduction, Adria. As Adria said, I've served with the Canadian Forces now for about 11 years in the reserves with the Cadet and Junior Ranger Support Group as both a cadet instructor and public affairs specialist. Prior to my injury, I was a very physically active guy. I enjoyed hiking, running, cycling, and swimming. I was very lucky to be part of the task force that took part in the Nijmegen marches in the Netherlands during the summer of 2013 as well. In the spring of 2018, I injured myself while jogging during PT, and now currently in the process of being medically released from the military. In 2018, when I did injure my foot, it was first thought to be a stubborn sprain that would just not get better. Further investigation in the fall of 2018 led to a diagnosis of several ligament tears in my foot, as well as something called complex regional pain syndrome. I had surgery in 2019 to fix the tears. However, that has exacerbated my CRPS symptoms, and I continue to suffer from CRPS to this day.
Thanks, Stephen. So veterans that come into our program at the Michael G. Group Pain Clinic, they're taught pain neurophysiology education as a sort of a cornerstone of their education, along with cognitive and behavioral skills to help them learn to manage their pain differently. On this slide, it's looking at what are the main components of pain neurophysiology education. And we're going to be touching base on these different points as we go through the presentation. But the main one I want to stress here is that learning about pain is therapy. So education about what's happening in your body and why helps you manage your pain differently. So Stephen, I'm going to ask you, prior to coming into our program, when you felt pain, what went through your mind? What were you feeling? What were you thinking?
That's a great question, Adria. I really saw pain as an obstacle that I needed to overcome. I felt that I could beat this. In my mind, all I had to do was ignore the pain and keep going. I can say now that I really had tunnel vision, and the only thing I saw was overcoming the injury, getting better, and returning to life as it was pre-injury. However, the more I tried to push through the pain, the more pain I would be in. The resulting effect would leave me in even worse shape, and I would be in a situation where I could not do anything, needing to lie down, sometimes for days, until the pain would come down to a level that allowed me to function again, at which time I would go back to trying to push through. It really, Adria, was a vicious circle that left me not only in constant pain, but also very angry and frustrated with myself and my injury. At night, I would often be in so much pain that I would lie in bed and all I could think about was cutting off my leg so I could get going again. This vicious cycle that had trapped myself in was not only impacting myself, but it was taking a tremendous toll on my family at home as well. They could see the pain I was in and had become increasingly frustrated with me that I could not just take it easy.
So as Stephen mentioned, it's this vicious cycle that we often see with patients that live with chronic pain. This overdoing, having elevated pain, and then having to rest and wait for the pain to settle before they carry on with doing things again. And as a physiotherapist that works with patients that have chronic pain and we're exercising, there are two things I typically see. When we're exercising and the pain goes up, patients will either push through. I got to push through this, no pain, no gain. I'm just going to ignore it. I don't want to appear weak. I want to get better. So I see this end of the spectrum. But the other end of the spectrum is what I see when people have pain with exercising is they feel pain. They think, oh, I don't want to cause more damage. I don't want to cause more problems. So they stop what they're doing. And they're concerned of causing more problems. And I see both of these extremes when people are exercising. And what we notice over time is this up and down cycle leads to people becoming more discouraged, more deconditioned, and more concerned that when they feel pain, it's causing more tissue damage. And this is where pain neurophysiology education, I find, comes in to be helpful. So there's some recent research that just came out in January of this year, and they asked patients who've completed pain neurophysiology education, and they asked them, what were the main concepts that you got out of pain neurophysiology education? And how were they helpful at managing your pain differently? So I've listed them here. And that first one, that the more pain you feel, the more damage you believe is occurring, is a concept that we're going to talk about for the next few slides. To have a better understanding of this, I'd like to give you a few examples. So I want you to think about if you fell and injured your knee. So we know there's tissue damage to that knee, you've fallen, but you fell and injured your knee just before you scored a winning goal in a soccer game. How would that pain be different than if you fell and injured your knee at work? Would there be a different perception of pain? The second example could be everyone slammed their finger in a door. So imagine you slammed your finger in the door. But how would your pain be felt if you play the violin for a living versus someone who's a dancer? Would there be a different perception of pain? when I'm explaining what's happening in our body and our nervous system, I like to sort of use analogies. And I like these analogies that I have up on the screen right now. I'm going to use the one on the left side. So we have this Jeep who's got an alarm system. The whole purpose of that alarm system is to sound an alarm if someone's trying to break in. But what happens if that alarm goes off when someone just brushes up against it? Or if a leaf brushes up against it? How effective would that alarm system be? It'd be overprotective. It'd be over-responsive. And the same thing can happen with our alarm systems in our body. The alarm system we have in our body is our nervous system. And it's made up of nerves, our spinal cord, and our brain. Now we have these special nerves that are called nociceptors, and they detect information that comes into our body that's deemed to be threatening. So extreme pressure, like hitting a hammer on your thumb or overstretching a muscle, extreme temperature, like hot or cold, or extreme chemical differences like inflammation. So I'm going to use this example of this gentleman who's picking up a box. He's picking up a box, and there's this warning message that's being sent through this nociceptor, this nerve, up his spinal cord to his brain. And this warning message is coming to the brain, and the brain is having to decide, is my body in danger? So the brain, if you could imagine, is the CEO of our nervous system. And the CEO of a company has to go to many different departments to make a decision of what's happening. The same thing happens with our brain. It has to go to many different regions to decide, gather information and decide, is my body in danger? So in this example where this gentleman's picking up this box, this warning message comes up to the brain, and the brain's going to use the present information like our five senses. And in this case, it's going to use his vision, the size of the box. The box is big, so that information is going to be interpreted as this could be dangerous. And as a result, these danger in me signals start to be produced. These excitatory signals, or these danger in me signals, we call them DIMs, start to be produced by our body. As well, this information is going to these different regions of our brain, and potentially to the region where we store past memories. And our brain's deciding, have I injured my back in the past? Have I had problems from this area of my brain, of my body before? And he's like, nope, I've never injured my back, but I had a friend who injured his back, and he never got back to work. So as a result, the brain is starting to produce more and more of these danger in me signals, these DIMs. He never got back to work. I have to work. I have my mortgage to pay for, my kids' programs to pay for. And as a result, more and more of these DIMs, or these danger in me signals, are being produced. And if there's more of these DIMs than these SIMs, or these safety in me signals, then our body's going to decide, yep, I need to be protected. How? Pain is going to be felt. So our body produces these excitatory, or DIMs, or these calming signals, these SIMs. Pain occurs when the brain decides there's more evidence of danger. In this past example that we talked about, have I had pain in the past? How did I manage it? How did my friend manage it? Or comparing it to the evidence of safety that's happening in the body. And examples of it would be, for this one, I've had a back injury, I got over it, or I've got a really great team that's going to help me manage my pain differently. So our brain has to take that information of the danger in me signals and the safety in me signals to decide what's happening in our body. As pain becomes more persistent, we see that often people aren't returning to work. They're often not doing a lot of hobbies and interests that they previously liked to do. And in some cases, they are not socializing or maybe hanging out with family or friends like they used to. And as a result, those safety in me signals, or those calming signals, aren't being produced by our body the same way. So they start to decrease. And at the same time, these excitatory signals, or these danger in me signals, start to get revved up more by the body. Why is this pain not going away? Why is there surgery, no surgery that can take it away? Why aren't medications helping? And you can see that there's becomes this imbalance of these danger in me signals and not a lot of these safety in me signals being produced. And this imbalance leads to this overprotective alarm system that we talked about. So this brings us to our second point, where thoughts, emotions, and experiences affect pain. And I'm going to talk a little bit about how most times when we're talking about what's happening in our body with these DIMS and SIMs, most people will get, yeah, I understand. Like I picked up that heavy box, or I twisted my back the wrong way. So I get it. There's these increase of DIMS. My body's perceiving that I need to be protected, and I feel pain. They seem to kind of grasp that idea. What I find interesting is that those DIMS aren't just from physical threats. Those DIMS are produced by our body with non-physical threats, like emotions and how we're feeling. So if we're feeling stressed or overwhelmed or angry, those same danger in me signals are being produced. And if there's more of those DIMS than those SIMs, then once again, our body is perceiving that it's in danger and it needs to be protected, and pain is felt. So I'm going to ask you, Stephen, do you notice a change in your pain at all when you're, depending on how you're feeling in it, or a change in your pain even when when it has nothing to do with movement?
Yeah, thanks, Adria. I think it's been a huge revelation for me to learn that the same pain alarm goes off when I'm angry or stressed. Now, having been through the program, I recognize how the more angry or frustrated I am is also setting off the pain alarm and making my pain feel to be much louder than it should be. At the same time, I've been dealing with the sadness over the loss of ability to do the things that I had once done before. And I can say that this too is also contributing to my pain. So I've learned that if I'm constantly focused on being mad, upset, frustrated, whatnot, that this too is feeding into the high level of pain that I experience.
Yeah, thanks for clarifying, Stephen. So this brings us on to our third point, where having that understanding that our pain is affected by both physical and non-physical is fantastic, but we want to understand there's actually something we can do about it. We can actually retrain this overprotective nervous system. Our nervous system can change. And I almost patients find it very empowering to realize that there are things they can do to decrease those danger in me signals. Learning what are their threats, what are the things that their body perceives as threatening, and managing them in a different way, as well as increasing their safety in me signals. There are things they can learn to do to increase those SIMs. And within our program, learning about pain neurophysiology education and why this is happening, but also some ways of altering those DIMS and increasing those SIMs. So I'm going to ask Stephen, when you were going through the Michael G. Group Pain Clinic, what are some things that you learned going through the program to help manage your pain differently?
The pain program has been an amazing opportunity for me. It's helped me understand how my pain is not so much a result of the injury itself, but my nervous system's response to it. It's also really helped me come to accept that this pain is something that indeed I can live with by managing it differently. And having been introduced to the concept of DIMS and SIMs through Adria and the rest of our team, I have gained an understanding on how to better manage my nervous system's responses and thereby improve my quality of life. I've also learned that I can still live and manage my pain, not by pushing through it, but rather listening to my body, pacing my activities, increasing my SIMs, and using breathing, relaxation, meditation each day. The program's also helped me adjust my medications so I can get a better, less interrupted sleep at night. And the fitness classes and physio sessions during the program have shown me safe exercises that I can regularly do on my own to help with my body and overall mood. I got to say, I'm actually feeling much more relaxed and less tense as a result. Understanding the DIMS, I now have a better understanding of what will exacerbate my pain and make it worse. Knowing that I can minimize these DIMS and increase the SIMs that help make me feel better I have changed my thinking toward my pain. Instead of spending each day trying to push through and beat this, I'm now coming to terms, accepting the pain and managing it so it does not control me like it once did.
Thanks very much, Stephen. That was a great summary. So we're going to leave it there to sort of talk about if there's any questions people might have regarding the pain neurophysiology education and even the approach that we use at our clinic.
Merci beaucoup, Adria. A very, very interesting presentation. Much of the frustration felt by Stephen is one that's felt by any veteran who has pain. We tend to try to ignore the pain, and then it descends into the vicious cycle you described, especially if the pain is chronic or persistent. As Adria points out, pain is personal, pain is real, but our nervous system can adapt to help us manage it. So we've had you submit questions in advance, so I'm going to ask our presenters to respond to these. Now let me go first to Adria. Can the human brain be retrained to block pain?
So I get a little bit wondering about the word blocking. I think of it more as a light switch with pain. You can't necessarily block or turn off that pain, but what you can actually do is, I think of it more as a dimmer, where you can turn down that pain response. You can turn down that sensitivity of the nervous system. And you do that by learning how to retrain your brain to respond to the input it's getting from the environment in a different way. And that input is coming through physical things, like we mentioned in the video, like movement and activity, or threats that are non-physical, like how we think and how we feel. So if we can retrain our brain to respond to these threats in a different way, that's how we start to make changes to the nervous system.
Thank you. So any veteran watching this presentation today, how can these veterans apply these lessons to improve their own well-being?
This is a good question. Thank you. So any ways that you could sort of start to be aware of what are ways I can increase the safety in me signals, these SIMs? What are some ways that I can increase those endogenous inhibitors that my body produces? And the SIMs are produced by things, but by doing things we enjoy, by doing things that make us feel calm, that make us feel safe. So for a physiotherapist, it's not necessarily having patients push through a huge exercise routine, but it's finding a couple of exercises that they find are comforting to do, that they feel they're helpful, and fitting them in regularly into their day. Or starting to use breathing techniques to help with that muscle tension and help with settling down their thoughts. So both of these are ways to increase their SIMs. Another thing is to start thinking about, what are some hobbies or interests that you previously liked to do? And even though you may not be able to do them the way you used to do them, maybe you could do them in a different way. And I have an example of a patient that used to be in our program a few years back, and she loved to play baseball. Her and her boyfriend were on a baseball team. And after the baseball game, they would have friends over for drinks. They would talk about the game. But she developed chronic pain and she wasn't able to return to playing baseball. She wasn't physically able to play baseball. And as a result, she didn't go to the games. She didn't have friends over. And she was becoming more and more isolated. And her SIMs, these safety me signals, were not being produced by her body anymore. After completing the program, she came to the realization, maybe I don't need to necessarily play baseball like the way I used to. Maybe I can still be involved in baseball in a different way. It doesn't always have to be all or nothing. So what happened was she started to attend the last few innings of the games, and she was the team statistician. So I'm not a big baseball fan, but I know a lot of people are, and I know there's a lot of stats involved with baseball. So she had a really important role on that team. And then over time, she started to attend longer periods of time at these games and taking the stats. She was part of the team again. And as a result, she started to produce more of these SIMs, more of these safety in me signals. She started socializing more. She started interacting. And sometimes when I work with patients with persistent pain, I notice they want to wait for their pain to be resolved or settled before they start to do things again. In this example, I'm trying to show you that Doesn't always have to be the exact same way, but starting to do things that increase those SIMs again. And that's when you start to make changes to your nervous system and start altering that pain.
Very interesting. Thank you. Now a question for Stephen. And thank you, Stephen, for sharing your experiences today. Now, on your journey to manage your own pain, what has been the hardest obstacle you've had to overcome?
Thank you for your questions, Sarah. I think that's a great one. For me, acceptance continues to be the most challenging obstacle to overcome. As I talked about in the presentation with Adria, the pain program really has helped me understand that my pain is something that I can live with by managing it differently. That being said, there are still days when I'm still really frustrated, angry, or even upset at myself for not being able to do the things as I once have been able to do them. In addition, to be honest, there are still times when I just want to push through the pain for whatever reason. However, it's in those moments that I'm now implementing the techniques that I've learned through the program that Adria has just spoke about, like breathing and mindfulness exercises to calm myself down. As well, I'm making a conscious effort each day to create SIMs for myself, whether that is sitting outside, listening to music, or doing some gentle stretches. These are just some of the things that I've been taught that are really helping reframe my thinking, allow me to begin to accept my pain, and thereby manage it differently.
That's great. Thank you very much for that, Stephen. Back to Adria. What resources do you recommend for those who would like to learn more about neuroscience and pain?
So there's some really great resources out there for patients that live with persistent pain. Accessing the Michael G. Group Pain Clinic, we have a website where there's patient education materials as well as audio recordings. If you're interested in some nice little snippets of education, you can also go on YouTube, and there's a couple of videos on YouTube. One is called Tame the Beast. A second one is called Why Things Hurt. And Pain BC did a great 3-part series that's available for patients to access. And it goes into more detail on the science of pain. If that's an interest of yours and you want to learn more about it, that's a great resource. And for any clinicians or case managers out there that want to learn more about it as well, there are courses. The NeuroOrtho Institute, which is out of Australia, has got some great courses, as well as some local physiotherapists from Canada. And one is Neil Pearson. He helped with that Pain BC recordings, as well as Carolyn Van Deeken, and she does a lot on the science of pain with pelvic health.
Thank you. And of course, we can't forget the Chronic Pain Center of Excellence website, which is also a great resource where you can find our series on well-being for veterans, and so many good resources out there. So the final question is for Stephen, and it's an important one, I think, for veterans themselves. If you could share a message with other veterans who are fighting pain, what would that be?
Another great question, sir. For veterans coping with pain, I want to share 2 messages with them. First, I think it's important to share with them that pain is not something that they need to try and push through or try to handle on their own. I really would urge other veterans suffering from pain to reach out and get help from programs such as the Michael G. Group Pain Clinic. While their pain can't be taken away from them, they can learn, like I have, ways to manage their pain differently, thereby improving their overall quality of life. Secondly, I strongly encourage those veterans suffering from persistent or chronic pain to find someone to talk to. Suffering from pain is an exhausting experience, both mentally and physically. Whether it is a counselor or a good buddy, having someone to speak with, in my opinion, goes a long way to dealing with the constant mental battle that we are challenged with as a result of being in this pain.
Excellent. Thank you very much, Adria, and thank you, Stephen, and thank you, everyone, for those questions. I remind you that these presentations will be available on the Center's website, and you can contact us for any other questions you might have after you listen to the presentations. So we'll now move to our second presentation. J'aimerais maintenant vous présenter notre deuxième conférencière. Joy McDermott is a physical therapist and epidemiologist and is co-director of the clinical research lab within the Roth McFarlane Hand and Upper Limb Center. She is also an associate professor of the School of Rehabilitation Science at McMaster University and she's cross-appointed to the Departments of Surgery and Epidemiology at both McMaster and Western University. Her numerous research projects address clinical questions related to enhancing the prevention, assessment, and management of musculoskeletal disorders and related work disability. Joy will be accompanied on the presentation by Robin Campbell, who's a serving member of the Canadian Forces and a member of the research team. Their presentation will explore pain treatment as it applies to different sexes and genders. Joy, over to you.
Thank you for joining us today. My name is Joy McDermott, and I'm joined by Robin Campbell. We're going to be talking to you about our project, which is identifying differences in chronic pain treatment needs and responses based on sex and gender in Canadian veterans, planning for future customized interventions. I'm now going to pass it over to Robin Campbell, who's going to introduce this topic.
Thank you. So I just wanted to say a couple quick words as a member of the research team, but also a member of our military community in a number of ways. So I am a naval reservist in the Canadian Navy. I'm also a spouse of a Reg Force member, and both my parents are Canadian veterans as well. So for me, I've seen firsthand the impact that chronic pain can have on our vets and how this impacts their lives as well as the lives of the families. So the topic today is really looking at sex and gender research and analysis and how critical it is to understanding chronic pain experiences from the perspective of sex and gender so we can better address the needs of our vets. We know that understanding this difference in experiences impacts the needs around treatment can be very different for different sexes and genders. And exploring this perspective can reveal important factors for better health outcomes for our veterans. For example, a U.S. study recently revealed that chronic pain can be more common, chronic pain syndrome can be more common among female vets. So why is that, and what might those needs be, and what might that look like? Better supporting our vets in this way and having this research can help us in doing that. So I'll give it back to Dr. McDermott, and she can explain the research study further.
Thank you, Robin. And so neither Robin or I have any disclosures, and we'll proceed. So some of the questions we're going to answer today is, why does sex and gender matter in chronic pain? Why is it hard for us to unpack sex and gender influences on pain? What have we as a research team done so far? Mostly talking about some research we looked at in terms of quantifying what's already been done, looking at sex and gender differences in response to treatment in chronic pain veterans in the published literature. Talk about what the team is going to do next to understand needs and gaps, what researchers can do better, and how can you help? So in this short presentation, we don't have time to discuss all the involved issues, but suffice to say that sex and gender matters in every aspect of your health. It certainly affects what risks you have for different injuries and diseases. It affects the disease processes themselves, how they manifest and how they progress. It affects your response to treatment and what outcomes you're likely to achieve. So clearly a very critical issue that should be very thoroughly discussed in all health research. This is a systematic review, a structured review of the literature that looks at all the published evidence on a topic, and it's looking at sex and gender differences, in this case, sex differences in the prevalence of musculoskeletal pain. And if you look at these graphs, they look at different health conditions, and if the blue bars go up, it means that women have higher rates of those types of pain. And if the blue bars go down, it means that men have higher rates of those types of pain. And the red bars indicate what the average is across all of those studies. And so looking at back pain, migraine, musculoskeletal pain, neuropathic pain, oral pain or dental pain, osteoarthritis, and widespread pain, you can see that almost all of the studies agree, and certainly the averages agree, that women have much higher prevalences of those types of pain in the general population. This is data from the general population. And this study, I think, which is the one that Robin alluded to, specifically looked at pain in veterans. And this was published in 2017 in one of the top pain journals. And it showed that women veterans have higher rates of pain. 11% of all women veterans have severe pain, higher rates of severe pain than men veterans, than women civilians, and also than men civilians. So why is it so hard for us to unpack sex and gender and include it in our discussions, our research, our interventions, and our policies? For one thing, it's very complex. There are many things, there are many dimensions to it, and there are many things that we don't know. But it's also hard to talk about. Some people feel a risk of speaking out due to sex and gender biases in our culture, in our world. And even people who want to talk about the issues and feel that they're very important are often worried about sounding insensitive because they may not fully appreciate the experiences of others. And we know that everyone has very different experiences based on their sex and gender. We know there are issues around power and privilege that are institutionalized, and this can make it difficult to talk about these topics and to affect change. We know that researchers tend to be uninformed, and only recently has there been an emphasis on the importance of sex and gender in health research. And we know that when services are stretched thin, it's difficult to spend time and energies on innovating when you're just adapting and coping with a large volume of needs. So when we talk about sex, we're talking about the biological attributes of humans and animals, which includes many things like your physical features, your chromosomes, your genes, your hormones, and your anatomy. And you don't need to be a scientist to know that females and males look differently and have different body structures. Gender, on the other hand, is a socially constructed idea, and it talks about our roles in society, how we're perceived, our behaviors, how we express ourselves, and our identities as girls, women, boys, and men, and gender diverse people. Gender is very complex and it has components to it. So obviously we can't study everything about gender in any single study. It requires a large body of literature for us to fully understand. But we talk about gender roles, which are the behavioral norms of how we are expected to behave, what jobs we have, and what stereotypes are about us based on our gender. Gender identity is how we see ourselves and how other people see us. Gender relations is more about how we are interacting with others or how we're treated by others based on our gender. And institutionalized gender is about distributions of power in political, educational, social, and health institutions. It's important to note that all of these things can affect your likelihood of developing chronic pain, what treatment you're likely to receive, and your outcomes of chronic pain. Although sex and gender are extremely important, we know they don't exist in isolation, that they interact. So we talk about an intersectional approach where sex and gender interact with other factors such as race, age, ethnicity, socioeconomic status, and many other factors that interact in very complex ways and can be challenging to understand. This is a study that just illustrates, and this is actually about heart disease, and heart disease is a very, very good illustration of how we've had to really rethink our understanding of sex and gender. So initially, heart disease was often thought as a disease that happened to males, and most of the research was done on males. Then we came to understand that, yeah, women die from heart disease too, and that it manifests itself very differently in females compared to males. Then this study, published in 2015, looked at gender, so how masculine trait or feminine traits that people had and how that affected heart disease. And what you'll see here is the red graph shows that for men with very masculine characteristics, were much more at risk of heart disease than men that had less of those characteristics, and that there was a very clear big hump in that pattern. But women, the pattern was different and the risks were very different. So gender didn't matter as much in heart disease for women, and that being more feminine was actually a higher risk for women slightly. So this just really illustrates how important it is for us to understand sex and gender when we study health conditions. And we're starting to do that in the pain world and understand that gender is actually as equally or maybe even more powerful in some cases than sex in determining the health experience. So this is the first step of what we decided to do. Let's go to the literature and look at what we already know about sex and gender from the published health research, so we have a strong foundation. And we used, again, a systematic review process where we design a very specific question and look at what literature addresses that question. So we were interested in active duty military and veterans. We looked at 2 interventions specifically, any kind of chronic pain rehab intervention, because we expected that both sex and gender would be important for that. And we also looked at any opioid intervention, because we know there are sex differences in response to opioids. And we felt these would be 2 areas that should be really looking at sex and gender in terms of differences. We looked at any kind of study that had any kind of treatment comparison in those kinds of studies. And we looked over 21 years of recent literature at all published randomized clinical trials. From that, we identified 21 eligible randomized trials that included active duty military and veterans having those treatments. And then we took sex and gender equity and health research guidelines and looked at the extent to which those studies met the criteria of those guidelines that researchers are supposed to be following. This slide just illustrates that you have to wade through a lot of research in order to get to those 21 studies. So we actually screened 14,000 studies in order to identify the 21 that addressed this specific topic. So we'll answer the questions. These are the questions that we answered. Did the authors talk about whether sex and or gender differences may be expected in chronic pain management in veterans? And the answer was no. All of the studies failed to report whether sex and or gender differences would be expected in treatment of chronic pain. Did the authors report how they studied sex and gender? And the answer is no. All of the studies failed to report how sex and gender were taken into account in the design of their study. In the results, did the authors report data based on sex and gender? And the answer is no. There were 20 studies that included both sex and gender in their question, and 2% to 60% of the sample was women in those studies. However, all of those studies that included both men and women failed to present the data disaggregated by men and women. So they didn't separate the data on the men and women to know whether there were any different responses. And there was 1 study that only included men participants. Then, did the authors discuss how sex and gender affected their results? And the answer was no. All of the studies failed to report the implications of their study for any sex and gender differences in the treatment responses. So obviously that was a very disappointing finding, and it means that the literature isn't going to tell us much about the differences between responses to chronic pain treatments based on sex and gender. The next phase of our research, which we're currently working on, is called a scoping review, where we're looking at what are the components of those programs, the multidisciplinary rehab programs for chronic pain in military veterans, and trying to see how those interventions are constructed and how they address different dimensions of chronic pain. From the work so far, we found out that only 8 of the 30 studies we've identified have provide any kind of conceptual framework to justify why the components of the treatment were designed the way that they were, although there is a common trend of patients reporting benefits from those programs in terms of knowledge, quality of life, and satisfaction with care. What we're using this for is to try to bring the evidence and needs together with the literature with a sex and gender lens to say, what are the treatment needs and targets? For example, what are the risks, health literacy issues, pain needs, and functional needs of patients, and how would those map onto different kinds of treatments? And you can see there's a list of different categories of treatments here and how those would be constructed into a comprehensive pain management program, considering sex and gender and different outcomes. So what are we doing next? The next stage after looking at the literature is to hear from veterans. So we're going to be doing surveys to give us large data, but also talking in detail to veterans to get more specific data, asking questions like, what are your needs and preferences? What types of interventions do you want and think would be helpful? What's the format that those interventions should be delivered? In the last year and a half, we've all experienced tremendous transitioning of interventions that used to be face-to-face into virtual interventions. So how should we think about that as we're moving forward? And what are the current gaps in care that could be addressed as we think about redesigning some of those interventions? We want to hear about what your experiences with care are, what helps, what doesn't help, and what are some of the access issues that might affect how interventions could be delivered most accessibly in the future. And in general, what kinds of suggestions you have for better care. We'll be doing another study where we're going to look at the physical and psychological suffering and symptoms that veterans experience and doing a statistical analysis that allows us to lump some of those things in together. In other words, what things tend to travel together so that as we create future programs, we can make recommendations about what specific clusters of things might be lumped together in treatment programs, knowing that everybody's different, but that treatment programs want to be comprehensive and useful to as many people as possible. And we're hoping that these will lead to recommendations that we're going to be useful to people developing future interventions in how to consider sex and gender, how to consider the clusters of symptoms, and how to consider what we currently know from the evidence about what things are effective in combination with the needs and preferences for better care and options in the future. So we can do better. That's certainly what we've learned so far. There's a lot of room for improvement, and that's hopefully we can contribute to some of that improvement, even though there's a long way to go. Some of the concrete things that we can do now are to check our own biases. Although there's much we don't know about sex and gender, we should always be reevaluating our presumptions and assumptions and see what we can challenge. We know that it's not just about women or men. Every cell has a sex and every person has a gender. And when those are not considered in health research, it adversely affects everyone. So we need to demand that researchers include sex and gender in future research. We should continue to ask about sex and gender differences and keep the conversation going, keep it always on people's minds in terms of asking researchers, but also asking healthcare providers, how does this intervention differ for me because I'm a man or a woman or a gender diverse person? And what do you know about that? And ask for sex and gender to be considered in health policy in the future. This simple slide here just shows how easy it is for us to be more inclusive when we collect data. We can ask about sex assigned at birth as being male, female, other, or prefer not to say. So we allow people to choose from an option, state something different than what we've given them for options, or not to answer at all. And we can ask about their current gender identity. And again, giving them options, but giving another response so that people who are gender diverse can claim what their identity is, and they can also choose not to answer. This is a very simple way to be inclusive in future research, but too often male and female, men and women are used interchangeably in research and people don't know which was actually collected. There are a lot of resources out there for researchers to do better in the future. The Canadian Institutes of Health Research offers training modules about how to incorporate sex and gender in your research. It's part of most grant submissions. There's gender-based analysis literature, and there are many case examples of showing how considering sex and gender in ways in designing interventions, we call gender transformative, taking sex and gender into account results in much better interventions for men, women, and gender diverse people. I'd like to acknowledge my team members who all contributed to the work that we've done so far. And I will stop there and thank you for listening, and I'm happy to answer any questions.
Merci beaucoup, Joy. As you can see, this research is innovative and will support veterans much more specifically in future. Our initial study of the literature shows that sex and gender impact chronic pain. Future research will provide more information and will enable the adjustment of the treatment of pain for different sexes and genders. We'll also seek, as Joy mentioned, the help of veterans in our research. So we're now going to move to the questions. Nous passerons maintenant aux questions. Joy, in doing your initial research, have you found that there are theories as to why women in general, and not necessarily veterans, suffer from chronic pain at a higher rate than men?
Thank you. Yes, we do know, particularly when it comes to musculoskeletal pain, that women tend to have much higher prevalence of health conditions with musculoskeletal problems and injuries, although there are some cases where men have higher incidence of certain kinds of health problems, and men are more at risk of high trauma injuries in the general population. So the types of injuries that people incur, how they incur them, are different. Two critical things that we need to remember, or three critical things I would say that pertain both to veterans and the general population, is one is that we have to think over the lifespan. The exposures that men and women have throughout the lifespan are very different. So for example, women have smaller bones than men. I really like the saying, women are not just small men. It's not that they're just smaller, their bodies are structured differently. So their bones are smaller. Upper extremities tend to be weaker than men in proportion to lower extremities. So women tend to have much more upper body injuries than men. And women tend to have higher endurance fibers and less power fibers than men. So they tend to incur very different kinds of injuries because of that. And we know that, so for example, with men, your bone strength increases until the age of 18, and that very slowly decreases throughout your lifespan. Whereas with women, your bone strength goes up and down with every pregnancy and changes with menopause. And so hormone influences bone very differently, and hormones influence every tissue in your body differently for men and women. We know that socially, men and women are exposed to different types of injuries because of the roles that they take on in society. We know that men and women, girls and boys, are more likely to be victims of sexual abuse or intimate partner violence. We know that if you are a victim of sexual abuse or intimate partner violence, that you're much higher risk of chronic pain, and particularly things like chronic regional pain syndrome, than are people who don't have those exposures in early life. And then finally, much of the early literature was done on male rats to determine how the whole pain processing system works. And researchers often didn't include any female rats in their studies because they said they messed up the data, they have cycles, it's a problem. And so our understanding of the pain processing systems was very much based on male rat data. And we now understand that the way that pain is processed through the entire nervous system is different for men and women. The pathways that are used, the receptors, the responses in the brain are different for men and women when we're looking at the pain processing systems. So when you put all of that together, it's totally expected that there would be differences between men and women in terms of pain, both in the general population and for veterans particularly.
That's very interesting, and obviously points to the fact that we should be treating pain differently for men and women. Thank you for that. And now, how about gender? How can gender, which is a socially constructed role, have an impact on physical health?
So the expectations of women and men in society influence what kinds of roles they take on in life, and they also influence what risk-taking behaviors they have in their recreational activities. So when you look at sports, for example, men tend to, boys and men tend to participate in high-risk sports to a greater extent than girls and women. That has changed somewhat over time because gender changes as society expectations change. So the roles that people have in life influence what kinds of exposures that they would have to having an injury. But also when we look at within occupations, and I'm not sure what how this relates to veterans, but in most occupations that have been examined, even when men and women do the same job, they don't do it the same way, and they don't have the same exposures in that job. They might be treated differently. They might have different risks of being of injury, but also of being treated in a less favorable way in that job. So just the fact that you have the same job doesn't mean that you're treated the same. And gender definitely influences that, which then influences chronic pain, because I think the first talk really highlighted how important the nervous system is in the way that we experience pain and how it influences that. So everything that happens to us influences our risk of chronic pain and how we experience pain.
Very good. Now for a question about specifically veterans. And so if a female veteran is living with chronic pain, how can she ensure her unique experience as a woman are recognized by different healthcare researchers and clinicians?
One of the challenges that often happens for any of the occupations, it's veterans, but also public safety personnel, where women tend to form a minority, is that sometimes researchers want to exclude them from research because there isn't enough sample size to do a good study of them. And so my first message would be to insist that even when there isn't a large number of women to study, that they should be included. One of the strategies we used is to try to recruit much wider geographic areas to make sure that we have enough women in studies in order to have a good sample. And in my experience, women know that they're not studied enough, so they're very willing to participate in research. So one thing is demanding that women be included in all research, and ask your healthcare professional, does this evidence, they say this drug is effective. Ask, was it proved to be effective for men and women or just for men? And keep it on everybody's minds that the evidence has to be for both men and women, and ask for the evidence about that. And constantly just asking for researchers and clinicians to be aware of the issues and to keep it on people's minds, I think is really important to demand that we do better in the future, because as we saw from the literature, we haven't done a good job so far. And hopefully, as we do our qualitative and quantitative work, we really are going to focus on asking women veterans what their experiences are and what their needs are for the future, that we hope will help to guide things a little bit better in the future.
Joy, this question is about response to treatment. Do people respond differently to pain treatment based on their sex or gender?
Yeah, so, and this study again was not a group, was not a study done particularly in veterans, but it was done trying to take a gender transformative approach to chronic pain management. And this was a work that I saw someone else present, and I'm sorry I don't have the reference off the top of my head, but for interventions for chronic pain that involve a lot of discussing, talking about things, and cognitive behavioral approaches seem to be much easier for women. Men seem to have more difficulty talking about their problems and acknowledging weakness. And so the intervention was talked about how there was a chronic pain support group for men, and it was all around building birdhouses. The men didn't want to get together to talk about their pain, but they were willing to get together and build birdhouses and then talk about their pain while they were building the birdhouses. So men needed this concrete thing to do. And there's evidence showing that men are more comfortable not looking directly in someone's face when they're talking about problems, whereas women are much more comfortable looking in someone's eyes and talking about their problems. And so building the birdhouses allowed the men to have a concrete task to do, which is much more important for men than women, and to focus on and able to talk about personal things without looking in each other's eyes. And it just showed, and the group was only men, no women allowed. So by considering the special needs of men in that particular case, the group was much more effective for men living with chronic pain than if they had considered, treating everybody the same is sometimes not the answer. It's meeting the individual needs of different genders.
Thanks, Joy. Now we're running out of time, but can you, in a couple of words, explain how veterans can engage with you to participate in the study?
I know the Center for Excellence keeps a list of people who are willing to participate in research. And so if you haven't already volunteered for that, I would encourage people to volunteer. And when we come to the stage where we're doing our surveys and interviews, we will be asking for those notices to be sent out through that list, and also using social media. So when you see invitations for participation in our studies, please volunteer. We're really looking forward to hearing from you.
Thank you very much. And this is all the time we have. And thank you to all of you for your presentations, for your answers to the questions, and for your research, which shows that there is indeed hope for improving the lives of veterans who suffer from chronic pain and their families. The Chronic Pain Center of Excellence for Canadian Veterans we'll continue to perform research on the best ways to treat chronic pain. We want to bring hope to all those suffering. We emphasize interdisciplinary services for chronic pain management, and the center is also creating a network of pain clinics across Canada where we encourage shared dialogue between the veterans who are being treated and those who are providing them care. As was evident in this seminar, veterans can get services across Canada, and there is hope that your pain can be managed. I want to remind you that a recording of this session and all our sessions is available on our website, and any question you might have can also be asked through the site. We're going to hold another session in this series next week on Wednesday, the 9th of June at noon Eastern Standard Time, and it will discuss first the current situation with chronic pain among Canadian veterans, to give you a bit of a sit rep, and secondly, the link between operational stress injuries and chronic pain and how to treat it in an interdisciplinary manner. We hope you'll join us then. On behalf of the Chronic Pain Center of Excellence, thank you for your presence. Merci beaucoup à tous et au revoir.